us are aware that surgical site infection is a huge problem in hospitals. And what we want to talk today is not only the clinical aspect, but also the emotional burden it carries to the patient and the families, and the economic burden to both the patient and the healthcare sector. And also just point out what truly works. We'll have briefly look at the global guidelines, the local realities, and of course the nurse-led solution, which is what this series is about, and how we could empower every nurse to stop infections before they start. So as I said, I'm not going to go too much into detail. I'll just sort of chart the course and build the platform for Captain Madhukari to take over. So when preparing this talk, I was, just drawing this parallel between a forest fire and surgical site infection. So how the forest fire, once it starts raging, it is very, very difficult to control the damage that the forest fire can, do to the environment, and how it starts with a small spark. And finally, what are the firefighting we can do to prevent these infections? So, or no, not prevent, but at least to eliminate or reduce the incidence of these surgical site infections. So I will probably end by telling that no, prevention is the best, I think, which all of us have as an ideal, but very rarely that we are able to put that into action. So what is surgical site infection? So according to the definition, it is an infection that occurs at or near the surgical incision within 30 days of the procedure. So this is if it's just a procedure without any prosthesis. If there is a prosthesis or implant which is implanted, then if any infection happens in that wound or nearby the wound, it is within 1 year of putting the implant. So this is the definition of surgical site infection, and this definition helps us to identify surgical infections with clarity. And what are the types of surgical site infection? We could broadly classify them as incisional or organ space. So incisional could be superficial or deep, so which just happens within the skin and fascia. So superficial just affects the skin and subcutaneous tissue, whereas deep also includes the deep soft tissue, fascia, and muscle. So that's the incisional type of surgical site infection. The organ space infections are those which affect the pleural and peritoneal cavities. So this is the types of surgical site infection we can have in our patients. So what is the burden of SSI? First, let us look at how the developed countries are doing. So here the data is readily available, and we could say that 2.5% of patients developed surgical site infection. That is the statistics available as of today. And if you look at all the healthcare associated infections, 20% of healthcare associated infections is contributed by SSI. So 1 out of 5 HAI will be a surgical site infection. And let's come to our region, the low and middle income group countries, of which India is also a part. Here it is much, much higher, almost 10 times higher than the developed countries, up to 20%. So there you could see there's only 2%. So that's the reason I wanted to highlight that that there is a lot of stretch, a lot of catching up we have to do in our region. So, and WHO's data says that 1 in 3 surgical patients may develop an SSI. So that's how common it is in the low and middle income group countries. So what about India? We do have some studies, and these studies there is variable incidence as low as 2.9 in some studies and up to 15 to 20%, especially in orthopedic, GA, and emergency and obstetrics surgeries. And it is seen that in a multi-center trial, hospitals with limited infrastructure record higher rates of infection naturally. So here is a graph which shows where data is available. It is quite old, so that's the reason I put that here. So things might have changed. It's almost 10-year-old data, but I couldn't find anything closer to our time period showing the breadth of information this has. As you can see, the developed countries is all between 2 to 2.5, and then it gradually keeps increasing, and India is somewhere here. It's about 15% is what the average SSI in our country. So why SSI is a critical problem? Why are you not taking this as a particular topic for this webinar? And why are we talking about it? So basically, there is, as I told you, it has got three types of impact. So one is the impact it has on the nursing workload and the healthcare impact, the patient and the impact of the patients and the families, and the economic and emotional toll. So this will give a much holistic picture of the impact of SSI. So what does the patient suffer from? Longer stay, anywhere between 5 to 20 days of an increased hospital stay. This could be in the ward or even it could be in the ICU. So depending on that, the cost goes up. An increased morbidity often leads to unplanned reoperations and ICU stay. And there is twice the type of mortality risk as compared to one patient who doesn't have a surgical site infection. So these are very important statistics to keep in mind. What about the economic and emotional toll? It's high out-of-pocket costs, sometimes to 3 to 4 times the cost of surgery, depending upon whether the patient has to get admitted in the ICU for the surgical site infection. Then the cost really skyrockets. Then the stress, pain, and delayed recovery, there is no cost which can be put to this. And of course, because if that patient happens to be the lone earning member for that particular family, then the whole family gets devastated. Not only is there loss of income, they sometimes pledge their property and to pay for the ICU costs. So there's a huge, economic burden on this surgical site infection, which is largely preventable. That is the tragedy of this. And of course, it affects the nursing and healthcare. Nurses are the ones who suffer most because of increases workload, affects the morale and patient trust. And already most of the hospitals are stretched, and this type of infections put additional burden on the resources and the manpower. So that's the effect of surgical site infections, or the impact of surgical site infections on the three aspects which I talked about. Now let's briefly look at what are the causes of surgical site infection, because if you know this, then we can easily prevent it. So I'm not going to talk about all the causes because there is quite a lot, but let us look at some of the key factors. So as I told you, the main difference between the hospitals or the incidence of surgical site infection seems to be resource constraints and infrastructure problems. So this is not easily corrected. That's a problem. So it is as opposed to others, HAI. Surgical site infections are peculiar in this. It requires a lot of investment of infrastructure and resource constraints to reduce the SSI. So that's why it becomes a problem. Poor infection control practices can be easily remedied. Patient and procedure related. These are sometimes which cannot be modified. If the procedure happens as an emergency, then definitely there is more chances of infection. And fourth is again in India, antimicrobial resistance. We're one of the, this one again, two things which India is notorious about: the diabetic capital of the world and the capital of antimicrobial resistance. Two notorious things which I think over the years we need to make amends. And of course, the training and skill gaps, which are a very, very important thing. So you could see some of them are modifiable, some of them are non-modifiable. So let us focus on the modifiable risk factors. That's what I'm going to touch upon next. Okay. So if you look at resource constraints and infrastructure, inadequate sterilization, water supply, overcrowding, poorly maintained OTs, lower nurse to patient ratios. So I'm not talking about infrastructure. Within the available infrastructure, can you provide proper sterilization, proper RO water and clean water supply. And can you avoid overcrowding, opening and closing those OT doors again and again, poorly maintained operating theaters, and providing adequate staff? All these are possible, and we should put these things in place to address the resource constraints and infrastructure. The next is the infection control practices. Again, hand hygiene, surgical asepsis, delayed or missing antibiotic prophylaxis, and whether weak surveillance or absent SSI surveillance and reporting systems. So these are all, again, remediable or modifiable factors in infection control practices. What about patient and procedure related? So the pre-op patients in our country, there are high rates of malnutrition, diabetes and anemia, emergency surgeries, long and invasive surgeries, and using reused or reprocessed instruments without any proper SOP, without proper guidance. So here some of them are modifiable, some of them are not modifiable. Again, antimicrobial resistance, we have high prevalence of MDR and frequently either unprescribed or incomplete antibiotics. It's the two ends of the spectrum. We know there is overuse and again inappropriate use. So these two are what is causing the antimicrobial resistance. And finally, the training and skill gaps. So inadequacy in continuous medical education or nursing education, surgeons and nurses not trained in the latest protocols. You have to keep up with time. The CDC protocols and other world-class protocols keep changing every year. So we need to keep up with the latest knowledge. And sometimes if you leave the junior staff unsupervised, then that could be another cause for these infections. So having looked at what are all the modifiable and non-modifiable risk factors, let us quickly look at how we can reduce it. So again, I'm looking at the low-hanging fruits. What can be modified quite easily? So one is ineffective pre-op skin preparation. All you got to do is get the patient to bathe with chlorhexidine soap on the morning of surgery. How many of us actually insist this on our patients? And then the incorrect timing and dose of antibiotics. How many times our patients are getting antibiotics within the 30-minute time frame for the antibiotic prophylaxis? And how many of us are actually doing the proper hand hygiene and infection control practices? And in the pre-op preparation, how good is our diabetic control? How strongly are we advising the no smoking thing in our patients pre-operatively? And sometimes prolonged surgeries cannot be avoided, but drain misuse, of course, can be avoided. So using evidence-based and guidelines on the proper use of drains also reduces infection and suboptimal wound care. So there is this concept of undisturbed wound care, which is now come into being. So when I started training in surgery, it was trained. I was trained to look at the wound on the first day, second day. In India, people sweat a lot, so we need to have a look at the wound. But now there are several studies which show that you don't need to actually disturb the wound for 2 days, especially if it is a clean operation. For an emergency operation, no, I'm not talking about it. If it is a clean elective operation, the concept today is undisturbed wound care. So you just leave the wound, dressing undisturbed for 48 to 72 hours. By the time the epithelium is sealed, and after that, the chances of infection are very less. So these are small changes in our practice, which will result in a great reduction in surgical site infections. So I just wanted to point out that we have the global guidelines by WHO. Again, it is the next edition is due anytime, but this is what we have: 2016 global guidelines by WHO. Why this is important? Because this is especially directed towards low and middle income group countries, taking into account the resource constraints that we have. On the other hand, the CDC guidelines is for well-equipped centers. So it's not that India doesn't have these sort of state-of-the-art facilities. Many state-of-the-art facilities are available in India, and they should follow these CDC guidelines. So depending on the infrastructure if we have, you need to follow one of these guidelines, and they all now provide the same type of results. In addition, we have looking at the antimicrobial resistance, follow the ICMR or AIMS infection control protocols to reduce the antimicrobial resistance. So these are all guidelines which are available, easily downloadable. So please make use of it, and using these, put the protocols in your hospital. So I already talked about the chlorhexidine hub scrub, the hair removal. This is another habit the surgeons cannot shrug off, right? We want the shaving to be done. And if this, patient's hair is removed the previous night, overnight, because of the micro abrasions, I think anybody who had used a razor and then the aftershave lotion will understand what is micro abrasion. So these are small abrasions which cause the burning sensation when you put the aftershave lotion. These small abrasions are a good culture medium for organisms to grow. And if you do it the previous night, within 12 hours, when we make the incision, you're making an incision through a good colony count of organisms, and that will increase the surgical site infection. So therefore, the hair removal has to be done as close to the surgical time as possible. So when I trained in the UK, it was the responsibility of the surgical team to do the hair removal in the patient reception area in the theater. So that's how close to the surgery we used to do. And that practice still continues in the West. And that's probably something which we can adopt. Okay. And also the prophylactic antibiotics has to be given within 60 minutes of the incision time. Intraoperative asepsis, limited OR traffic. Now, we did a small, quick audit on how many times the theater doors open and close in a 1 hour surgery. You'll be surprised at the number of times it opens and closes. So every time it opens and closes, you lose the positive pressure in the operating theater. So these are small things which we could change very easily. And then maintaining the glycemic control, because we have a lot of incidents of diabetes, and we need to emphasize on that. The anesthetists have to be careful about this. And also the normothermia, putting those blankets, keeping the temperature constant. And of course, postoperative we already talked about. So I'll end my my sort of setting the stage session with just telling how can the nurses lead the fight. And I think they have a very multifactorial role, unlike the surgeons. The surgeons can do only at the time of surgery, whereas the nurses can have leadership roles, by becoming infection control champions, conducting pre-op education, participating in the antibiotic stewardship program. Operational roles by putting the SOPs in place, monitoring the antibiotic timing and surveillance. And finally, education and advocacy in their own hospitals. So I think nurses have a huge role in preventing SSI, and that's the reason we are so happy to have eminent and nursing leaders addressing you all in this series. So friends, let me now end by telling that prevention is the most cost-effective solution. You saw the amount of emotional and economic burden this type of infection causes, and we should try to prevent these. And I also will add that nurses serve as the primary line of defense against SSI. So with this, I'll end, and I will hand over to Stella to introduce our distinguished speaker for today. Thank you so much.
Thank you so much, sir. Thank you for all your insights through the story. No. And I'm so excited to listen to Captain Madhukari. So I'm so privileged to welcome you here, ma'am, Director of Nursing for the Eastern Region at Apollo Multi-Speciality Hospitals, Kolkata. She also served as a Director of Nursing Services at Evercare Hospital, CK Birla Atmos Health Institute, where she has significantly contributed during their commissioning phases. And she holds a master's in business administration, and she's a certified simulation instructor level 1 Six Sigma Green Belt Lean in Healthcare certification. She received the Nursing Excellence Award from AHPI in the year of 2016 and currently serves as a national vice president of the Infusion Nurses Society, INS, and founding member and West Bengal chapter president of Association of Nurse Executives in ANE. She has authored research published in the International Journal of Scientific Research and presented in the European Society of Pediatric Infectious Diseases Conference in Copenhagen, passionate about quality initiatives, and she is a certified auditor for quality accreditation of India and infuse auditor of INS India. Beyond her professional commitment, I just was excited to read out about your profile when I come across at the last. She has no she's actually deeply dedicated in caring for stray animals. Actually, no very special persons will have this kind of humanity towards the stray animals. Like, welcome you here, ma'am.
Thank you so much, Stella. I'm really thankful that you have touched my very, very soft corner, and that my soft corner is taking care of the stray dogs, and that's my passion, more like just like my job. So it's very close to my heart. So thank you for mentioning this, because this gives me a lot of warmth with the session that I'm going to talk. And I'm really thankful to Dr. Pari from SkillMed, and also Kaho and Shilke, all of them, to give me this opportunity to be one of the speakers, because it is the challenge. We have seen Dr. Pari presenting very well about different dimensions of surgical site infections, which actually talks about that how important it is for us to know where we can go wrong and where we can really take it up. So as a challenge to make or to create a difference in every aspect and in every step that we do, and we take care of surgical patients. So thank you once again for giving me this opportunity. Let me just share my screen so that I can start with my PPT. Is my screen visible?
Yeah, your screen is visible, ma'am.
And it is in slide mode. Yeah. Okay. So very apt topic of infection control, and I think every hospital is tracking and every hospital is taking it as one of the initiatives to reduce infections. And we all know hospital acquired infection. This is one of the components, like other components like COTI, CLAPSI, and VAP. This is SSI is one of the components of a hospital acquired infection, which is to be taken care by all caregivers. It is a team collaborative approach. It's a team of surgeon, anesthetist, and why you will ask later on, I will definitely come up with that, why anesthetist is also important as a part of surgical site infection. I will definitely mention that. So it's a team of surgeons, anesthetists, the OR nurses, the ICU and other nurses, technicians, and all those who are involved in direct caregivers, CSSD technicians, CSSD protocols. So everything is important in terms of reducing surgical site infection and a global burden. So I'm sure that at the end of the session, the attendees are going to learn about what are the risk factors related to surgical site infections, which Dr. Pari has narrated very well, whether it is patient related, it is procedure related, or it is operating room related. There are some basic practices in acute care setting to reduce the surgical site infections. And it is important for us that we know what are the preventive measures that can be taken care, that can be monitored also for compliance. It's very, very important for all of us, because it is not only the burden for us, it is burden for the patient. It's also burden for the organization, because if the organization is of repute, is having so high incidences of surgical site infections, it's going to not to talk good about the organization performance. So directly the impact comes on the organizational performance in terms of successful surgeries. So surgical site infection definition, I don't have to talk. Dr. Pari has clearly mentioned about it. It helps in increasing LOS, it helps in increasing morbidity, mortality, length of stay we are talking about, and also ultimately it boils down to the cost. So educating ourselves, then not only the nurses, doctors, everybody in the system, and also educating patient and patient family is very, very important, because ultimately it is how the patients are going to accept it, and then how they are going to take care pre and post. That's very, very important. So education for patient on the risk factors, education on patients and families on preventive measures is very, very, as I said, is a collaborative approach, and it has got its own legacy of taking care of it, in a sense that it will be very, very useful for us to know and take care of it. So Dr. Puri has already explained about types of surgical site infection. It is superficial, deep, and organ space. So we know that superficial and deep are directly connected to incisional wounds, which actually affects the skin, the subcutaneous tissue, and subsequently deep affects the fascia and muscle and organ space, of course. But where we see that incisional wounds, that requires 30 days surveillance. So every hospital, definitely, as we are tracking SSI, we are definitely, I'm sure we are doing 30 days surveillance from the date of surgery, and organ space where implants are there, so 90 days surveillance. So we are able to see within 1 year on if implant is placed or involves any part of the anatomy, what is the, whether there is any infection, and that can, how that can be taken care of. So I'm not going to this because anatomy has already been explained very well by Dr. Pari. About these, that he was talking about the cost. It is Indian scenario. If we take, there are some studies, some study. One of the studies that I was seeing when I was going through, I was seeing that it talks about that one SSI can lead to additional costs of 60,000 rupees for healthcare cost per patient. And for patient, it can be 7,000 in and out of pocket expenses per day for patient. So it's a huge burden for patient. And we know that which indicates that India has roughly 1.5 million SSI cases annually. So it increases minimum, on an average, it has been seen 7 days hospitalized days. Is 60% more likely to spend time in ICU, 5 times more likely to be readmitted within 30 days of discharge, and it is twice as likely to die. So you can well imagine the magnitude of the problem once the patient develops surgical site infections, what a patient has to undergo, not only the length of stay, also the ICU stay, and then the readmissions and the out-of-pocket expenses, and ultimately the death. So this outcome is never good if it is not taken care of. And we know, as it has been already discussed, that factors which are responsible for, but then once we go through the nerve from the nursing point of view, the factors which are responsible, patient related factors, which first comes preoperative bathing or showering. Now, many a times what happens, we tell patient that you take this antimicrobial solution, go and take bath, but we forget to explain how the bath has to be taken. We do not explain that. We do not take care of the operative side, how the microbial skin burden can be reduced if the bathing is being done properly and showering is being done. First of all, it has to be ensured that minimum 2 bathing has been done. When the patient gets admitted, or after admission, one bath is given and another bath is given after the clipping has been done on the day of morning of the surgery. So it's very, very important. And to ensure that clipping is also done within the stipulated time, I'm coming to that, that clipping is to be done within 6 hours of surgery, so that it helps in reducing the burden of microbial skin flora to develop. So, and then the next comes the managing underlying health conditions. As Dr. Pari also mentioned, obesity, diabetes, smoking. These are the situations where these are very, very high risk factors which can lead to SSI. So according to CDC, they also say that these burdens to be reduced. So we have to ensure that patient is being counseled about all this, and well control of diabetes has been done prior the patient is taken for surgery. So I think every hospital has come up now to understand that shaving is not the indication. Shaving should not be done. It should be the razor, and clippers to be shaving with razors should not be done. It should be clipping. So clippers are recommended for hair removal because because razors, we know that it can irritate the skin and it can open up the skin to have more chance of having infections. So after that, it is a patient factor also talks about perioperative glucose control. So it is perioperative, that means pre, intra, and post glucose monitoring, glucose control is very, very important. So every hospital should have a proper structured surgical site infection prevention checklist or bundle, which should have a range of glucose to be maintained per patient. That has to be intraoperative. That's very, very important message and important factor which needs to be regulated, which needs to be monitored constantly. Coming to the surgical environment and technique, where we have antimicrobial prophylaxis, as Dr. Pari was talking, so right time within, now we talk about that within 60 minutes of incision, the antibiotic has to be given. But it is 60 minutes means it may be 5 minutes, it may be 10 minutes, or it may be 55 minutes. But whether what is more important in that also, if you do minutely, minimum 20 minutes before, 20 to 25 minutes before the incision is given, we should consider that. It may be that formula talks about, or the guideline talks about within 60 minutes of incision, but it should not be that within 5 minutes, just I give antibiotics and within 5 minutes patient, the incision is being done. That is not a correct thing. Minimum 20 to 25 minutes in advance, the antibiotic should be given before the skin incision is given. That's very important, even though it is within 60 minutes, but this portion is very important. Now, maintaining normothermia is also very, very important point, which Dr. Pari has mentioned. So during surgery, whether patient is being warmed properly, patients, even the intravenous fluids that we are using, whether that is being warmed and before giving it. Even we say that skin preparation solution, suppose in the morning, first case we have taken, and the skin preparation solution is kept inside the OT with the what temperature of 16 to 17, or you see within 18-degree temperature, it gets cold, the normal temperature too, it becomes very cold. Now, if you are using it for next patient, we should not be using that same fluid, because it is already very cold. It should not be poured on the skin. So it should be taken out from the direct operation room, so that it is not very cold that we should apply for the next patient. We should not do that. These are minute details, but these are very, very important, because pre-warming and hypothermia, maintenance of keeping the patient in normothermia, avoiding hypothermia is very, very important, because hypothermia is another cause of having SSI to a great extent. So maintaining, that's why it is being said, the guideline says, prior to surgery, all adult patients scheduled for neuraxial, general, or combined anesthesia are pre-warmed with a forced air warming device and on its high temperature setting for at least 10 minutes before if the surgery starts. So it's very, very important. This is a very good guideline which talks about how to maintain, why normothermia is so important to reduce the risk of infection, SSI. So appropriate skin preparation is one of another component where chlorhexidine gluconate and alcohol-based solution can effectively reduce the skin bacteria. So when the skin hand hygiene is being done or surgical scrubbing is being done, we have to ensure what sort of combination of products that we are using. So this is the right combination of products which are supposed to be used. Now, minimizing traffic in the operating room is another factor which is very, very important. As Dr. Pari was saying, that too many times opening the door when the surgery is going on is not recommended. Also, the number of people that they will be remaining in the operating room is very, very important. Because number of people depends on to minimize the contamination inside the OT. So when we talk, so this is the second factor. When we talk about this is part of intra-op. Now we talk about postoperative care. In postoperative care, it is important that proper wound care is being taken, which Dr. Bari has already mentioned. Prompt treatment and infections, that means right kind of antibiotic has been used in terms of the sensitivity pattern, and patient education, patient and family education is very, very important. So in the entire surgical gamut, it is important that duration of scrub, skin asepsis, surgical attire that is being used by the surgeons and the other team members, draping that are done for the patients, duration of surgery, because duration of surgery will also decide that whether prophylactic antibiotic redosing has to be done or not, wound class, prophylaxis, traffic in the ward, temperature and humidity maintenance inside the OT. The patient factor is glucose control of the patient, temperature control of the patient, foreign materials that are there. That's why sponge count, instrument sponge count, the drapes count is very, very important. Now the types of surgical drains that are being used and surgical techniques, all these are responsible and they are influential to develop SSIs. Other factors like if the patient has compromised health status, like chronic illness, unhealthy lifestyle, advanced age, these are detrimental to have, to have high risk. These type of patients are at high risk to develop infections, surgical site infections. And most infections are caused by germs found on or in patient's body that enter surgical site. That's why pre-op bath is very, very important, because if pre-op bath is not being taken care properly, it has to be, the patient has to be told they have to wet the body first, and then they have to take this antimicrobial solution in their hand, circulate in circular motion. They have to apply it on the body and on the part where the surgery is going to happen. This is very, very important to explain to the patient, and then the bath to be taken. Otherwise, this antimicrobial solution will not have any effect. So outside sources of contamination like surgical personnel, surgical environment, and instruments and air, these are also responsible for creating infection to the patients. Now, we know that how we calculate SSI rate. Now, SSI rate is because ultimately we have to know where we stand as per the, we have to benchmark ourselves as per the industries, as per the standard guidelines. So if we want to benchmark, what is the formula that we need to do, how we calculate our SSI. So a calculation that determines the percentage of, because these calculation, these SSI rate, it actually talks about what is the percentage of surgical procedures resulting in SSI. So it has to be calculated by dividing the number of culture positive specimens by the total number of surgeries performed, multiplying by 100, because it's a rate. But if we talk about risk of SSI, in that case, asepsis score is very important, which actually categorizes the wound, that satisfactory healing is happening post-op or not. So it is another factor which actually gives clue that what sort of antibiotic you have to you have to give to the patient. Also, what sort of wound care that you have to do. So asepsis score is talking about the satisfactory healing is 0 to 10, but if there is a disturbance in healing, if the score is between 11 to 20, there is a disturbance in healing. If there is a chance of minor SSI, we'll call it when the score is between 21 to 30. 31 to 40 is going to be a moderate SSI, and the severe SSI is anything the score is more than 40. So there is a scale which talks about that, depending on the type of wound, the exudates that from the wound. So in the and the healing that happens, so that we can measure these type of scoring, and we can see that how we have to go further go ahead with the antibiotics and the wound care that we have to do in terms of dressings. So as we have already spoken, so it is very important for us that how we do SSI prevention controlling in terms of ward traffic. So each person entering in the ward should be, that is an additional screen for us, screen flora and the risk of contamination. So opening the doors too many times, as we have already spoken, and 15 to 30 air exchanges are very important. So to ensure that, we have to ensure that we have HEPA filter, which actually talks about that what sort of air exchanges are happening, to ensure that we have good positive pressure inside the OT to maintain. So it is very important for us that we monitor the pressure inside ward and in the corridor. The differential pressure gauge is being maintained, that at least we should have 2.5 pascals pressure difference between the inside the ward and the corridor outside. So that we are able to ensure that positive pressure is maintained inside the OT. So the other important factor is room and equipment cleaning. After each case, how the room and equipment needs to be cleaned before taking up the next case is very, very important. So terminal cleaning daily is critical in preventing the healthcare associated with the SSI infection. So dust and the disinfection of critical equipment, dust which can be from the human skin, hair, fabrics, seed pollens, powders, the gloves, the paper fibers, all are used. From there the dust comes. Then the critical equipment which is being touched by everybody. So how the equipment is being cleaned, disinfected, that's also very important after each use with an EPA registered disinfectant, and it is dried before each use or storage. And sterilization of critical equipment supplies and high level disinfection is very, very important wherever it is applicable. Antibiotic therapy, as rightly Dr. Padi was talking about, and I was also mentioning about 0 to 60 hours. And in case of any surgery prolonged for more than 3 hours, the repeat dose of antibiotic redosing is very, very important as a prophylactic antibiotic. So, in terms of nursing care, post-operative prevention of SSI is very, very important. As I was talking about, maintaining normothermia, which is more than 96.8, because hypothermia actually impairs the immune system and it causes a vasoconstriction at the incision site, which actually helps to invade to actually cause compromises the circulation and the healing of process of the wound. So proper hand hygiene, sterile dressing maintenance, delivering of antibiotics as directed in the same intervals and in the right dose and in the right manner, so that entire administration process is being foolproof. Then monitoring and maintaining adequate blood glucose level post-op and providing nutrition, balanced nutrition, hydration is very important. As a nurse, we are supposed to be ensuring that these are being maintained at all levels till the time patient is discharged. And after discharge also, if the patient needs to continue this, our responsibility lies even then. Once the patient gets discharged, our responsibility doesn't get ended. It also includes that at home patient is able to take safe care. So it's important for us on all these aspects, we educate our patients to ensure that patients are safe even at home if they have to continue with the treatment. So, and we have to educate our patients on the different signs and symptoms of SSI, like pain at the operating site, swelling, tenderness, redness of surgical site, fever, drainage. Now, drainage can be purulent, drainage can be greenish yellow or bad smelling, or so immediately they have to report. They have to be told that immediately they have to report to the clinician, to the surgeon, so that it can be well taken care of at right time. It is not the delay. And the moment it is purulent discharge, it has to be considered as SSI. So the treatment will include wound care, debridement if it is required, medications, oxygen therapy, wound vac therapy, the vacuum dressing, which actually create a negative pressure to take out all exudates from the wounds and helps in wound epithelialization. So controlling other diseases impacting like diabetes, it has to be every time we are talking about diabetes, because diabetes is a major cause of concern in terms of exercise. So diabetic control is very, very important. So now it is important for us that we talk about discharge instructions. So as I was telling that it is very important for patient and patient family to learn about discharge. So dressing maintenance at home, proper incision care, taking bath in surgery does not mean that patient will not take bath. Patient has to take bath, but how it is to be taken, taking incision care, that's very, very important. That has to be taught to the patient and patient family. Symptoms of the SSI and reporting it well in time. Hand hygiene to maintain at home before and after dressing is very, very important. Nutritional guidelines, what a high protein has to be taken if there is no contraindication in terms of renal insufficiency, and everything that has to be corroborated with the nutrition that we advise. Medications, blood glucose monitoring, bathing instructions, and follow-up appointments. These are the important factors which have to be taken into consideration when we discharge a patient with after surgery. And this is a QR code I have just mentioned, just to show you that in Apollo, I'm just talking about through this QR code, we have created some QR codes where we are giving actually video-based learning. Once they scan the QR code, they will get a video to see that how they are supposed to be continuing dressing at home, whether they do themselves or they get it done by the caregivers, but other caregivers or somebody comes at home to do dressing. If the patient and patient family knows what is the right method of dressing, they will ensure that dressing is being done by the caregivers even at home in the same fashion, so that they can prevent infection, but it is our responsibility. So this is one of the ways that we are educating our patients. I just thought of sharing it because there are many, many such innovative ways by which we can actually take care of such patients, those who have to continue care at home. Just giving an example, classical example of clinical scenario. Here, Mr. A is a 68 years old male. He was admitted for an elective surgery of TKR due to chronic osteoarthritis. And this procedure was classified as a clean surgery, but the patient had multiple comorbidities that significantly increased the risk for postoperative complications or SSI. And his medical history included that he was type 2, he was having type 2 diabetic mellitus, and he was hypertensive, he was having also obesity, his BMI was very high, chronic, and he was also suffering from COPD, chronic obstructive pulmonary disease, and he was also a very regular smoker, chain smoker, 30-pack years smoking history. So during surgery, the patient developed intraoperative hypoglycemia. CBG was 62 milligram per deciliter, which went undetected until the postoperative phase due to a lapse in glucose monitoring. So see, intraop. The operation was further complicated by excessive blood loss, requiring volume replacement. Despite being a clean surgical procedure, these intraoperative challenges combined with poor glycemic control and impairment tissue oxygenation during intra and postoperative period led to the development of deep incisional surgical site infection on postoperative days. So what happened after that? What all clinical courses that had undergone pre-op assessment missed detailed glycemic status, whereas his HB1AC was 9.1. It was very high glycemic control, but not addressed urgently. Antibiotic prophylaxis given 20 minutes after incision, which is actually was supposed to be given within 60 minutes of incision, not within the recommended time. Post-op wound dressing was delayed due to availability of surgery team. Patient returned with worsening wound condition. Dressing found to be improperly done at home, developed wound dehiscence with foul-smelling discharge. Readmitted for surgical wound debridement, glucose control, and supervised wound care. Wound culture was showing Pseudomonas aeruginosa, confirmed deep surgical site infection SSI, required wound debridement and prolonged IV antibiotics, and was discharged after 18 days with home nursing care. So the entire SSI risk model, which includes age, BMI, diabetes, smoking, and the procedure type, everything was included in that, which went haywards. So then it really prompted us to have a structured. Of course, we had, but we also revised. We followed AORN, CDC, and WHO guidelines for preoperative part preparation checklist. We instituted, which included actually hair removal is done with clippers or not. Preoperative showers have been taken as per the recommended process or not. So it is a chlorhexidine 4%. Actually, it is being mentioned in our pre-op checklist that do not use chlorhexidine on the scalp, face, or non-intact skin of the patient. So it is not recommended for use of children below 2 months of age. These are the directives which have to be mentioned and which have to be maintained at all times. So we'll also have to see, each nurse has to see preoperatively whether skin is intact or not. History of pre-existing infection, if it is there, to mention it in the chart. And diabetes mellitus, what is the sugar control, what is the glycemic control? It is below 6, it is between 6.01 to 7 or not, it is more than 7 or not. Similarly, fasting blood sugar is below 180, it is in between 180 to 200, or it is more than 200. So these are the general components with which the floor nurse, ward nurse is supposed to be handing over to the OT nurse. When they are taking, OT nurse is taking over. After that OT nurse is taking over, that will be part of intraoperative SSI prevention bundle, which will talk about the operating room was cleaned thoroughly before the surgery. The war room temperature and humidity were well maintained. Name of the prophylactic antibiotics which are given within 60 minutes of incision. The date and time needs to be mentioned. Name of the redosing antibiotics if it is more than 3 to 4 hours surgery. Then if the patient is diabetic, then patient remain normoglycemic during surgery, which actually, and again it is being monitored if the surgery is prolonged surgery. And what is the value that has to be mentioned? What is the patient's body temperature, that needs to be mentioned. Equipment sterilization, whether it was done or not, again it is very, very important that we have seen. And then name of the surgery and the duration of surgery is very, very important, which is again the part of intraoperative surgery. Now, as a post-operative surgery, again, the bundle is very, very important where it has to be mentioned POD1, POD2, POD3, POD4, up to POD7 or 8. What is the condition of the wound, with wound and the other parameters which needs to be taken into consideration as a post-operative SSI checklist, which includes hand hygiene when assessing the wound, hand hygiene when dressing the wound, aseptic technique is being followed when the dressing is done, glycemic control is well maintained below 180 milligram per deciliter. There is no fever, or if there is a fever, then it has to be notified immediately. It has to be documented. Local incision site needs to be inspected, whether there is any tenderness, redness, swelling, pain, discharge at the site of surgery, so that it can be immediately intimated to the surgeon. So these are coming as a part of post-op surgery, and it is directly nurse's responsibility to ensure that these are being captured and notified in proper time. Just as an initiative, I want to say that when we found that this type of things are going on, and the case study that I have given, I have explained, we have opened a nurse-led wound clinic, and we had been sourcing patients from two different areas. One is OP, one is IP. In Apollo, when we have opened this wound clinic, our wound clinic nurses, one nurse goes to inpatient area where they are doing the liaising between the patient and the surgeon, and then they're dressing when it is going on, they are inspecting, they are taking picture of the wound status, and they are continuously monitoring on the healing, whether wound is healing or not. And also they are liaising with the patient family and all the surgeon, so that when patient goes on discharge, they keep on monitoring the patient's wound, and then subsequently they report to the surgeon about the healing. If they feel that patient needs to be now coming to surgeon wants to show the wound, then in that case they are doing the liaising work to call the patient to the hospital again to show to the surgeon, so that, and if they need any antibiotic, if they need any different kind of dressing, that can be assisted at all times. So that continuous monitoring even at home, that goes on. In OP area, there we have different procedure rooms. So different procedure rooms, patients are being notified where there the nurses are doing, when they are doing dressing, they are doing everything. They are notifying the surgeon. Surgeon is also coming and looking at the wound. And if any patient has to continue with the dressing at home, then the similar kind of taking care and video-based monitoring is being done. The patient and patient family comes to the wound clinic. They give education to the patient by leaflets, by videos in different languages, and they also show different videos how dressing has to be done at home, so that they are being well equipped about that. They are well educated about the wound. They are well equipped with the dressing that has to continue, and the importance of antibiotics to go on if they have to continue antibiotics at home. With that, the continuous monitoring by the wound care nurse, so that it can be, and to a greater extent, I will show a graph where it will show that this is the look at the rate of SSI that has reduced. In October 24, we had the highest rate, that was 0.96. By doing all this that we have come to know, not only by educating patients even on discharge, when patient was staying in the hospital, our responsibility starts from the pre-op stage, and even to continue at home. By July 25, we have achieved best performance at 0.13%. So you can well imagine that these all precautions if the nurses take, they can do a dramatic change in terms of SSI, and the patients can be saved. So these are the references which I wanted to talk about, that we are also considering the ORN. We have undergone the hospital, we have taken initiative that our OR has undergone the AORN audit, and we have done lot of such, we have taken lot of such initiatives which helped us to ensure that our surgical site infection reduces to a great extent. Thank you so much.
Thank you so much, ma'am. This was a very useful session, and you have given us the in-depth knowledge about like how to prevent the SSI in the healthcare system. Thank you so much, ma'am. Lots of, as usual, like lots of hearting and thumbs up is like over the screen for you after your presentation.
To take up any questions if they have.
Yes,
Because
yes,
we
ma'am.
have been talking many things, yeah.
Yes, yes. And sir, do you want to say something before we can we
I
could
wanted
proceed
to
with the
point
Q&A?
out that we have expert nurse in the panel who was OT in charge. Stella in a
Okay.
previous thing was OT in charge, and has a lot of knowledge about this SSI and all that. So I think our job will be easier. She'll take most of the
Yes.
questions.
Thank you so much, sir. Yeah, thank you. We'll take up the questions now, ma'am.
Sure, we are ready.
Yeah, okay. So there was the first question. This one question, I got it from the YouTube. That is like, in which all cases antibiotic is not required.
See, if it is a superficial surgery in terms of skin, and then this very superficial surgery, in that case, antibiotic may not be required. It is only profile. Even for the surgeries which are only prophylactic antibiotic as per the antibiogram of the organization is good enough. So some organizations say that only redosing of second dose is important. Some organizations say the third dose maximum can be given for major surgeries, but that prophylactic antibiotic is good enough. You don't have to give otherwise if the patient doesn't have any comorbidities. I will ask Dr. Pari to answer further because he's a surgeon. He will be able to enlighten about the antibiotics furthermore.
Yeah, see, basically, you're talking about prophylactic antibiotics. Is that what the question?
I think the question is related to the prophylactic antibiotics, sir.
Okay. So see, you can classify the surgical wounds into 4 types, right? The clean, contaminated, and dirty.
Contaminated, dirty.
Okay, so the clean are the ones which are on the, as Captain pointed out, it is on the surface. It doesn't involve the pleural or peritoneal cavities or the intraluminal portion of the gut. Okay, so all the lumps and bumps excision, breast surgeries. So these are all come under clean surgeries. So for these, there is no need for prophylactic antibiotics. So we don't give prophylactic antibiotics for these surgeries. The prophylactic antibiotic mainly comes under the clean contaminated. Here is the potential for getting infected. So these are things where the lumen of either the respiratory tract or the GI tract is entered. Say, for example, GI surgeries, cholecystectomy, and things like that. So for these, prophylactic antibiotics are required. The other thing which I have to add is in clean surgeries, if you are using implants, for example, if you're using a hernia surgery using a Prolene mesh, then definitely prophylactic antibiotics are required. So clean with implants, clean contaminated. These 2 types of wounds alone require prophylactic antibiotics. The contaminated and dirty wounds, it is therapy. You need to give them for 7 days, not just for 24 hours. So the prophylaxis happens only in these 2 types of wounds.
Yes, sir. Yeah. And there's another question. So this is the question from Miss Amalinda. So the question, I think we could try to answer for it, because can serous discharge be considered as SSI? So I feel so that serous discharge is from the surgical side. So the question was very, it's a very vague question. Yes. So if at all the serous discharge is from, yes, sir, you were talking something.
Another clear criteria of diagnosing SSI.
Yes.
Okay, so
Yes.
either you send that discharge for culture and sensitivity.
Yes.
And if it proves, yes, that's
Yes.
number one.
Yes.
If there is redness and swelling around the wound clinically, the nurse can make a diagnosis of surgical site infection.
Yes.
The third is if the surgeon has opened the wound with a suspicion of surgical site infection, then also it comes under the diagnosis of surgical site infection. And the fourth is if the surgeon calls it an infection, nobody can question it, right? If the surgeon himself says it's infection, because we try to be, saying no, it's not infection. But if the surgeon says it's infection, if the surgeon has opened the wound with the suspicion of an infection, A discharge which is sent to the lab and shows the culture positive, or if there is clinical signs of redness and swelling around the wound, these four criteria show that it is a surgical site infection. These are all it's not my definition, it is from the guidelines.
Yes. And there is another question asking for like, is that do we have to give antibiotics, prophylactic antibiotic for the LSCS case? Yes, of course. They have to give it for the the cesarean sessions. Of course, it's recommended. And there is another question: how to follow up surgery patient for 30 days and 90 days? Any checklist? So this is the question
Yeah, and you
asked
can
by
have.
Ms. Pramila. Yeah.
Yeah, of course, there is a set checklist which needs to be created. You can also create your own checklist because you know that what all you have to capture by now. What is the type of wound, whether there is any discharge, whether there is any warmth, any redness, whether it is painful. So there are these type of questions that which actually indicates the signs and symptoms of SSI. It should be part of that checklist. And since when patient is having, when last antibiotic was taken, how long antibiotic was taken, whether there is any fever or not. This should be part of the checklist, which has to be created, and each patient has to be called. That what is, and follow up has to be done over call, over video calling, and over calling out to the patient, because many a times it happens that patient is unable to say that what antibiotic patient is taking, whether any change of antibiotic that has been taken. Patient is unable to say that whether when last, the patient may not be remembering when last antibiotic was taken. So in that case, we'll have to involve the patient relative also, who is the taking care, next of kin, who is taking care of patient at home. It may be an attendant, it may be a home care nurse who is taking care of. So we have to take information from those people also, the right kind of information. So a checklist has to be made based on which, and there has to be structured checklist based on which the question has to be done, so that you come to know that whether patient has developed any surgical site infection which needs to be taken care immediately. Checklist is important.
Yes. Yes. Rightly said, ma'am. Yeah. And there is another question about like. Okay. So the same question, do we have to repeat the antibiotics after 3 hours? Like the answers have been shared already. And there is a question about like how does antibiotic helps when it's directly applied on wounds? I saw some of the doctor putting antibiotic powder on wound while closure. Like that's the question. I think the systemic antibiotics are very welcome when it comes to the surgery more than a topical antibiotic powder. Am I right, sir? So you're on mute.
I would want Captain to answer that.
Yes, yes, ma'am.
Of course, because local application of antibiotics, it is more of antiseptics which can be used in case of, and it is like wound should have the components which are being used for which will actually improve healing. So there is, if there is like if the wound should be clean. There has to be, we have to ensure that we prepare a good wound bed, which actually the wound bleeds or wound is very looks like there is a circulation, proper circulation is happening. In that case, we will do a dressing with a material which will help in epithelialization, and it will help in promoting healing. So local antibiotics and not giving systemic antibiotic may not be recommended.
Yes, yes. Thank you so much, ma'am. And there is another question again, like the patient underwent vaginal hysterectomy. If postoperative vaginal swab, if it is positive, it is considered as a SSI.
Yeah, we already told that. No, that's
Yes,
one of
it's
the
very simple. Like,
criteria.
no, I just make them clear, sir. Whenever the surgery is done, post surgery, you're taking any swab from the surgical site and the report is coming as positive, it considered to be SSI. Okay, so I think it would be like clear for you all.
Goes without
And
saying.
yes, ma'am. Yeah, so we'll go to the Q&A portal. Okay, can we say it as SSI when sample collected during surgery becomes positive in a patient? No, it is actually post-procedural. Okay, can we say it SSI when sample collect? Okay, I'm sorry, sir. Okay, we track post-operative patient through phone calls and it is difficult to keep a track on them during surveillance period. It's about the challenges they are facing. They are explaining here, ma'am. Like they are like tracking the patients like through the over the phone call after the post-operative phase. How frequently can they be tracked for effective follow-up? They're asking your suggestion, like once a week, or what is your opinion about that, ma'am?
See, if the wound healing is going well and there is no chance of SSI, patient is doing very well, need not to continue antibiotics at home, then in that case, once in a week calling is good enough. But if the wound is not doing good, then I think every third day calling is must.
Yes, yes.
Because we
Well,
cannot make the patient wait with the infected wound for 7 days and then we do something, intervention. Intervention has to be done at the earliest.
yes, yes. I think Dr. Saravana Priya, you have been answered for this. Like, I think you have got a clear idea from Captain Madhukari. And there is another question. What about, like, they're asking you, like, about what about the chlorhexidine bath in endourological surgeries?
Endourological surgeries also, see, it is recommended for any surgeries unless and until the skin should be intact. Chlorhexidine bath is recommended as long as the skin is intact. If the skin is not intact, then it is not recommended.
Yes, yes. And the
Just
same question there.
1 minute. See,
Yes, sir.
the in endourological surgeries, now the main problem is UTI, not surgical site infection.
Yes.
Okay, so giving a chlorhexidine bath, there is not much of evidence. People have not really studied that. But it's the one principle in quality is if you give exceptions, you say this patient you give bath, this patient you don't give bath, then the whole the whole protocol will fall apart. And this is not something which
Yeah.
So this is not something which
Patients
is very harmful. So we can do it for everyone.
and also patient's skin flora is responsible for developing. So if the burden is high in the skin flora, that itself is maybe a cause of infection. So by all means, we should be doing more of prevention.
Yeah.
So
Okay. Yeah, got it. And there is another like they're asking about your from out of your session, ma'am. Like it's about you have mentioned about the code practice for the health education. How effective it was? That's the question from one of our like participant, Ms. Sridevi Shantaraju.
So it was very effective because nowadays everybody knows how to use mobile. Even if they are not literate, also they know how to scan it. And you can show them when they are coming to you on discharge. You can show them this is the way the scanning has to be done. The moment scanning is being done, there is a video which can be seen in a language that they want. We have made it in 3 languages. Our local language is Bengali, Hindi, and English, so that they can opt for which language they want to understand. So they can opt for that language and they can open the video and they can just go through the video how it is talking about dressing, the process, the method of doing dressing at home to continue, so that it is very easy to understand, very easy to follow. We should actually, whatever education material we make, we should make it very simplified, in a simplified way, so that it is being understood well. Otherwise whole purpose gets defeated if it is made with lot of lot of stuff, lot of big words. It doesn't actually suffice the purpose. So it has to be in a simplified format, in a simplified language that they understand, and it should be small and crisp, that they understand the method of dressing, so that they have to continue at home. That's very useful.
I equally support the QR code system, ma'am, because once I was working in earlier, my career started in Apollo Hospital. Because all the nurses, when they go for the rounds or working with the patient, they have any doubt, like scanning the QR code will give them the great impact. Instead, going searching into the file, searching for the document where it is like available. So it's like instant, ready-made, ready recurrent for the nurses who are working in the healthcare organization. Thank you so much, ma'am. And there is another question about. Is everyday wound dressing required after surgery, or is there any schedule? I think Dr. Pari have explained it very clearly, like how we have to manage the wounds and how many months we would consider, how many months we would we should consider for SSI if any organ transplant is done for the patient?
It's the same. I mean, it doesn't vary for organ transplant. There's no specific uh, different definitions for SSI. It's the same.
Okay, sir. Okay. So from your point, they have asked another question, sir. Like it's about whether the prophylaxis antibiotics to be given for all the cases, or is there any specificity for clean or clean with contaminated dirty cases?
I think there's a lot of questions and still confusion. So let me clarify.
Yes.
If I go through the comments and Q&A, there's quite a lot of... That's because the practice is varying. So unfortunately, surgeons have their own whims and fancies. The guidelines are very clear. And it's probably because in every hospital you see the surgeons, each one is practicing in their own way. That is why there is so much of confusion. See, the wounds can be classified as clean, contaminated, and dirty. I hope this is clear, right? Contaminated, no confusion. Already the infection is there even before you start the surgery. Okay? And the amount of contamination is very high, like in road traffic accidents and all that. It is considered a dirty wound. Contaminated and dirty is not for prophylaxis because the infection is already present when you're making the incision. So this is therapy. For this, you need to give 5 to 7 days of antibiotics. So we are not talking about contaminated or dirty wounds. So that is out. So you have these only two things: clean, contaminated. Now, clean wounds are those which are done on the skin and subcutaneous tissue, be it a small sebaceous cyst in the scalp, or lipoma, or even a major surgery like breast surgery. All these are restricted to the skin and subcutaneous tissue. For these, no antibiotics are required. In our hospital and in our policy, there's no antibiotic. If 100% of the surgeons are following this, no. But the guidelines are very clear. Clean antibiotics, no need for prophylactic. Clean surgery, there is no need for prophylactic antibiotics. Only in the clean contaminated, that is where you go beyond the skin and subcutaneous tissue, into the pleural and peritoneal cavities, into the gut, well-prepared gut. If it is an emergency surgery and is not a prepared gut, it becomes contaminated. That is a different thing. Whereas if elective colectomy, I have prepared the gut well, and it only needs 24 hours of antibiotics. So that is the guidelines, only clean contaminated. You need prophylactic antibiotics. The exception to clean surgery is when you are using an implant. If, for example, in hernia surgery, it is still only skin and subcutaneous tissue, I put a mesh, then I'll give prophylactic antibiotics. So I hope I made myself clear.
Yes. Yes, sir. And
We have to understand the difference between the prophylactic antibiotic and definitive therapy, what Dr. Pari is talking. Patient is, before surgery, patient is already getting antibiotic. That comes as a part of definitive therapy. So and then same antibiotic you are continuing intra-op and then post-op. That is not prophylactic. Prophylactic is when only for surgery that you are giving. So that is 1 or 2 doses, not more than that. So that differentiation has to be understood well. Then it is very easy, the way sir is very well explaining about clean and clean contaminated.
yes, this is actually a common query among all the nurses when it comes to antibiotics. What is the prophylactic and what is the therapeutic antibiotics? Always a confusion. I think the explanations were very clear now. And there is another question, like how exactly can we do the SSI surveillance, especially if the number of surgeries are more? Like, can I also give some suggestions, ma'am? What yes, okay, what we done is like we had all of a sudden the number of surgeries increased when I was in abroad, like how to do the follow-up for the patients. It was very difficult for my nurses. So what we did is like we did it like innovations like automated messages to the patient party, so that a nurse, we should not, we don't have to waste the resources. Like resources is our nurses, like we don't have to waste the time and energy spending on that, so that the automated messages will go set up on the reminders to the patient, so that we can collect the information of the patient. And we were tracking the patients in an excellent way. We were able to track the patients who have SSI, and also you can send it across even the digitalized form to the patient, so that they can fill up the difficulties whatever they have. So that's how we were doing it up, ma'am. as your point of view,
Also, it
ma'am.
is very important. Also, it is very important that we know that, see, every wound or every surgery is not going to go bad, or it doesn't need a long follow-up. It may be
Yes.
only first three, after 3 days you do first follow-up, maybe second follow-up. After that, it is not required. In that case, patient otherwise also comes after 10 days to the OPD for showing. So those wounds may not be requiring whole month, but yes, you have to educate patient. As she's saying, you can have a common feedback system by which patient will automatically put if they have any symptoms within 30 days. That needs to be educated that well so that they can intimate you also. So it can be
Yes.
both the ways. It can be a combination of phone calls, combination of follow-up, and with self-calling or self-intimation, like information from the patient side.
Stella, I
Yes.
think,
Yes.
let me just clarify this. I think there's a
Yes.
question about implants and the SSI definition.
Yes.
So now the previous definition only said 30 days, but now it has been changed for implants, it is 1 year.
Yes.
I think this is, you need to follow that.
True. And there is another question, like I think Miss Silikuti have asked. I have a one concern. 30 days time period is very crucial. In case they are poorly manage the wound at home, so how we can consider this as HAI? In further, they have to limit the days like within 15 days.
Don't blame the patient.
Yeah.
No, no, I
So
think, we have to be very strong in this. Anything which happens, any infection happens within 30 days has originated in the hospital. Don't say
okay.
that because of the poor, wound management at home.
Yes. And
And we are
also the health.
responsible for
Yes.
it.
Yes. And the health teaching, as Captain Madhukari was like mentioning about this, is very important for the patient who getting discharged from the hospital after the surgery. The health teaching is very important. How to take care of the wounds at home, how they are going to manage it. That health teaching is like, is to be on the peak when they also know they get adequate knowledge. Equally, they should be a half a nurse when they go to home to take care of that such kind of care to the patient. Yes. So I think I've covered all the questions, sir. Most of the questions were very repetitive, and they were having a lot of confusions among the antibiotics about the surgery. The same questions were put forth. I think both of the people, like, they have covered all of your questions a very well manner, and hope you all have cleared your mind about the SSI concept. And thank you so much. And sir, please.
Yeah, Mr. Rajaraman, you can want to say a few words. Again,
I
I
think,
have to take this opportunity to thank Shulke for proposing this project and supporting us. I think this has been a really very successful series of webinars. We have never seen such interest in online webinars to this extent. And thank you so much, Mr. Rajaraman, for supporting this.
yeah,
Yes.
thank you. I think I need to thank you and the speakers. I think they made the difference. We just had a brainstorming session. So that's it.
True. Sorry
Thanks,
to
Doc.
interrupt, sir. Sorry to interrupt, sir. Meanwhile, the session is getting over. The link for the today's webinar, where you're going to get the certificate for the for the participation to this webinar. So please click that link and fill the form and submit, so that after 48 hours of time, or after that, you will be getting the certificates through your mail. Thank you so much.
Yeah, if
Mr.
you don't click and then ask for certificates, we cannot give because the technology doesn't work that way. So
Yes.
you need to have click that link and put in your name, and otherwise, see, we cannot manually write certificates for such a large number of people. So we are using technology. So once we enter your name, make sure you enter your name properly, because the name is directly transferred to the certificate and print and given and sent to you as a PDF. So please use the link and enter the details.
And also, in addition to Dr. Pari's view, I have ended up with few questions from the webinar participant asking. We have put forth all the details while filling up the form while registering. And why do we have to fill the form again at the end of the session? That is actually the thing what we have said. You stay with us connected through the entire webinar program till the end. You get the real benefit out of the speakers and then fill the form and get the certificate. So that's the whole concept behind it. Okay. I think you all will.
Registration is different from attendance.
Yes. Yes, this is the attendance. Yeah. Yes.
Okay, so
Yes, sir.
thanks, Stella. So I think I need to thank Captain Madhukari Ray. I think she took the entire checklist, line by line. I think it's just not should be on paper; it should be implemented. I think that was a great learning I took forward. So thanks, Dr. Pari, for once again moderating and setting the stage. Thanks to Skills for My team for wonderful coordination. And thanks to all the participants for being here, even we overshot by 30 minutes. So thank you all very much.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you.
So we
So,
can
yeah, yes,
out,
sir. Captain and Doctor and Mr. Rajaraman can go ahead with your regular routines. So I'll be there for another. Yes, thank you so much, ma'am.